Stephanie, and I'm talking about client privacy and confidentiality. All helping professionals encounter privacy and confidentiality when they decide how much information to give family members, other professionals, and outside programs. Without proper guidelines for confidentiality, patient information would be available for everybody, and that would pose a risk for clients. This presentation will reflect on the nuances in confidentiality as it pertains to different populations, specifically substance abuse. It will also explore limits to confidentiality and the risks associated with keeping all client information confidential, as well as the risk to not reporting imminent harm. So HIPAA is a federal law that was enacted in order to help set a national standard to protect patient health information from being released without consent. This is according to the CDC. And HIPAA is also known as the Health Insurance Portability and Accountability Act of 1996. Now, before HIPAA, not all the privacy of all populations were federally regulated. Most marriage and family therapists who were working with substance abusers were employed by a drug or alcohol treatment program, and they were unaware of the confidentiality with this population and the fact that it differed from others because it was almost entirely controlled by federal law. Laws have changed since then. As we see with HIPAA, it was enacted 16 years later, which assured that every population was federally regulated, regardless of diagnosis and place of treatment. So, limits to confidentiality are clearly defined in the AAMFT Code of Ethics. However, all mental health professionals go by this, as well as healthcare professionals in general. So the limits include if a client is posing imminent harm to themselves or to others, cases of ongoing abuse and court orders. The American Psychological Association gives more details about what is considered a limit to confidentiality. They describe that any time a patient or the public need protection from harm due to suicide or other actions that could be harmful to others. When discussing ongoing abuse, the APA states that ongoing domestic violence is considered ongoing abuse, so as well as abuse and neglect of children and people with disabilities, including the elderly. The abuse does not need to be reported if it is an adult describing their own childhood abuse, as it happened in the past and it is not ongoing. The APA explained that court orders usually happen when a person's mental health comes into question during legal proceedings, and they're not usually common. Information about diagnosis and treatment are usually shared with insurance companies, and that does not break confidentiality law and ethics as it's necessary in order for insurance to know what they are covering. Because they are receiving sensitive and confidential documents, insurance companies are usually bound by HIPAA laws. When mental health professionals intend on sharing information with other healthcare professionals, it is required that they get consent from the client before sharing any information. Mental health professionals share client information with other healthcare professionals in order to help coordinate client care. There's often a gray area of privacy and confidentiality when it comes to minors under the age of 18 who want to receive services without their parents knowing. The APA reports that the ages in which people can seek mental health services without informing their parents varies within different states. In most cases, a parent is involved. When minors are attending therapy where parents want to be involved, the psychotherapist, child, and parent do sit together to discuss ground rules for privacy. Parents usually agree to be informed if their child is engaging in risky behavior. Many clients may not know how much to share or what to include when talking to therapists, as they're afraid about their confidentiality, and ultimately, it's up to the client to decide what to share. This is according to the American Psychological Association. Most states have laws that either require or permit mental health professionals to disclose information of clients who are a harm to themselves or others, according to the National Conference of State Legislators. New Mexico is a state that has permissive duty to warn laws. 4 states that do not have any duty to warn laws include Nevada, North Dakota, North Carolina, and Maine. Like most laws, there's a reason why steps have been taken to make reporting ethically mandatory. And an example of this is the Jablonski by Pauls versus United States case of 1983. This is one where failure to warn led to the murder of Melinda Kimball. So Melinda's daughter was able to maintain an action against the United States due to its failure to warn her mother of her danger. So Melinda, her murderer, was a man she was living with whose name was Jablonski. He was a psychiatric outpatient at a Veterans Administration or VA hospital, and his government psychiatrist had assumed responsibility for his care. On July 7th of 1978, Jablonski threatened Kimball with a sharp object, and he threatened to rape her. After several obscene phone calls to her daughter, and as well as malicious acts, Jablonski volunteered to undergo psychiatric examination at a hospital. The police immediately called the VA hospital and were informed that Jablonski would be treated by Dr. Kapilov. However, Kapilov was unable to come to the phone in order to speak to police, so police spoke to Dr. Berman instead. Dr. Berman was the head of the psychiatric service and discussed the patient's violent behavior with police, who did recommend inpatient services. Dr. Berman failed to notify Kapilov. On July 10th of the same year, Kimball drove Jablonski to the VA hospital. On that visit, Kapilov learned that Jablonski had served 5 years for rape of his wife, who had he'd been with before Kimball, and he attempted to rape Kimball 4 days prior to this day. Jablonski stated that he had undergone psychiatric treatment, but he refused to tell Dr. Kapilov where he received treatment. Dr. Kapilov diagnosed Kimball with antisocial personality and was considered potentially dangerous. Kapilov did not see this as an emergency or as a basis for involuntary hospitalization. He told Jablonski to return in 2 weeks. Kapilov stated that he did not report to Kimball that Jablonski was potentially dangerous because Kimball stated that she loved Jablonski, and Dr. Kapilov thought that she would not listen to him. So as we see in this case, reporting could have been life-saving to the client's family member, and if Kapilov reported to Kimball that she was in danger and advised her to stay away from Jablonski, she would have potentially avoided that fatal incident. Aside from confidentiality, poor documentation by Dr. Berman can also be a separate ethical issue to discuss. Now I'm going to present an interview with a recent doctor of pharmacy graduate who has been working with clients for 4 years. The reason why I chose to interview him is because as mental health professionals, we do work with healthcare professionals on psychotropic medication, antidepressants, antistimulants. So I thought it would be interesting to hear a pharmacist's view on patient privacy and confidentiality. So for my interview, I'll be talking to Miguel. Miguel just finished his degree, a Doctor of Pharmacy at NMSU. He has worked with patients for 4 years while doing his program. So, Miguel, I was wondering if you could tell us more about yourself.
Yeah, my name is Miguel Hernandez. I recently graduated from UNM with my Doctor of Pharmacy degree. It's a 4-year program considered graduate school once you get into pharmacy degree, and of course there's prerequisites to that. And like you said, we work with patients throughout our time at school. Starting at the end of our first year, we take the summer and go to a pharmacy to work for basically the summer, just to learn kind of how pharmacies run. And then during our third year, we go to a hospital setting and we do patient notes to make sure they're correct, and learn kind of how to go about writing them and making sure that all the patient needs are taken care of. And then our entire fourth year is going to a bunch of different pharmacy sites to kind of learn the different aspects of pharmacy, whether it's working like at a Walgreens or in a hospital or maybe even like a clinic site. And so I've had a good amount of experience working with patients throughout schooling, and my career is just starting, so I don't know the full extent of just being thrown in yet, but we'll get there soon.
That's exciting. So as pharmacists, we work directly. So as an MFT student, or even mental health professionals, we work directly with pharmacists, doctors, and you guys are authorized personnel who we could send sensitive client information to, and we do get their consent before we do it. Along with that, we are bound by HIPAA, and we do respect our patients' privacy and confidentiality. However, there are limits to that, and those limits include if there's a potential for harm for themselves or for others. Also, if there's ongoing abuse, or if there's a court order. And I was wondering if it's the same thing for pharmacists. Are there limits to confidentiality?
Yeah, so kind of just like you, we're all bound by the same law, which is the HIPAA, and that's there to protect patient privacy to their health records. So we can't just be giving out sensitive information to whoever we want. We have to go through the proper channels. We have the same limitations as you guys. If we suspect harm to themselves or to someone else, abuse, and court orders as well would give us that. Of course, we all would access different aspects of HIPAA law. So some of the things that you guys are usually going through, maybe dealing with like family members most of the time, or stuff like that, we might not see as often, especially if we're in more of a store setting like Walgreens or something like that. Of course, people do have relatives or whatnot come and pick up their medication, and if they're authorized to do so, they have to know like their date of birth and some stuff to get through kind of the initial clearing, and then we would hand over the medication in that way. But for the most part, we're bound typically by the same rules as you guys.
Yeah, and I know that usually it's quick when you go to a pharmacy. There's not much time that you have with your patients.
Mm-hmm.
Given that we usually have an hour, I'm sure you have like 15 minutes or 20 minutes with yours.
Yeah, it depends. Like I said, in a store setting like Walgreens, CVS, and stuff like that, yeah, it would be more of a quick thing. We typically see patients after they've just gotten their prescription, so they've already been at a visit or something, or picking up refills to stuff they've been taking for a long time. So they're not necessarily in a talkative mood most of the time, but of course we are there to answer any questions they have and help them with whatever they need. But if we're more in like a hospital setting, we might not even see patients at all. Some pharmacists could be seeing patients all day. It kind of depends on the role that you're in. Also in pharmacy, to see kind of who you're going to be interacting with more and the kind of the group of people you're going to be interacting with.
Yeah, so it varies depending.
Mm-hmm.
So
yeah, it varies a lot.
Yeah, and do your clients know or hear it from you what their confidentiality like rights are? Like in a way, do you go over that consent with them? Is that how it works in pharmacy, or is it something that they just kind of expect?
So typically the only time we would actually talk to them about that would be when someone's requesting something. So if it's like let's say a wife is calling to request information about the husband, if they don't have the proper like documentation saying that they're able to, we might tell them like, we can't give this information to you. He'll have to call us or he'll have to tell us, and then we'll be able to give it out to you. I have heard from some of my preceptors, which are the pharmacists that are in charge of us as we're students going through, that they've had people who have tried to come and like get this information from the pharmacy for like reasons that aren't appropriate, and so like they're mad at them, so they want to check, or they want to check to see if they're spreading any kind of diseases to other people and stuff like that isn't really appropriate for them to know, because it's protected information. And so stuff like that is when we would discuss to them like, hey, we're not authorized to give you this information. They'll have to come and get it themselves. But for the most part, we're not really discussing with them their HIPAA rights in like a direct manner. In hospital settings, we like everyone would sign their forms and stuff like that, and it's in albeit complicated languages, kind of what we're allowed to give and what we're not allowed to give. So that could be an issue too, where people don't really understand what they're signing their rights to. But other than that, we're not really talking to them directly about what is protected information versus what isn't.
Yeah. So it might come with the hospitals, like with the actual packets that they sign.
Yeah, so in those packets, it's all of their, like the waivers and saying that we're allowed to treat them, and it'll have right there that their information is protected and that they have a right to the information and stuff like that, that we typically might not always read through, but it's in there somewhere, mostly to protect the hospitals, but.
Just like the legality of it all.
Right, exactly.
So that being said, I know you mentioned sometimes people will try to get information for like malicious reasons. Is there like a certain personnel that you tell client confidences to? Like, do you limit it to only family members who know the information and their doctors, or who else would you discuss these things with? So for example, MFTs, they discuss it with doctors, and then as well, like family members, only if their limits to confidentiality is breached, but we mostly just discuss it with their doctors actually. So are there certain personnel who you would talk to?
Yeah, so typically we would discuss information again with our colleagues, like doctors, nurses, anyone who's around that's authorized to view that kind of information. Techs also, pharmacy techs are able to see that. Basically anyone that works for the clinic, pharmacy, or hospital is supposed to be HIPAA trained for the most part, I believe, and so they all understand how to use that information. I do know that in clinics, if someone has a person with them during the visit, that's giving them kind of authorization to hear what's going on. Of course, they always have the right to excuse someone or say that they don't want someone in. During my times in other sites, at other pharmacies while I was working there, there were times where we would go and visit with the patients, and we would let them know that I was a student and that if it was okay for me to visit, and sometimes they would say no and they only wanted to discuss with the person that they were there to see. So I would have to wait outside. And so stuff like that, they're always, of course, allowed to do. They're always allowed to bring somebody. And again, that's where those forms would come in saying like, hey, if someone comes in, they're allowed to hear what's going on and they're going to know. And I feel like they understand that for the most part, but directly sharing like their profiles or any notes that are written about them, it would have to go directly to the person. And then from there, they would share it with whoever they want to share it with. Yeah. So.
Yeah. So I heard you say that they sign off on it. So they would give like written authorization that it's okay for you?
For the most part, I believe there's always some forms in there that you do sign regarding the confidentiality. And then, like I said, people are always allowed to say who they want to be there during the visit. And for the most part, they would take someone who wants to be there or doesn't want to be there. And they're allowed to say if they want someone to not be there during the visit, such as like students or other personnel that are working there.
Yeah. So it could also be verbalized.
Yeah, but for the most part, like if we're giving out written documentation, it would directly go to the patient that it's related to. So a family member couldn't come in and ask for like a note or an X-ray picture or something like that. It would have to go directly to the person who it was related to.
Oh, okay. So if it's something like a documentation, only that patient can have it. But when it's like the medicine, if the family member knows their date of birth and other stuff, they could take it.
Yeah, basically.
Okay.
So for medication pickup, if they know their date of birth, the full name of the person, that we're usually allowed to give that to them. Of course, it's in a bag, so we're assuming that anything in there would be, I guess, safe in a sense. But yeah, if they know date of birth and full name, they're allowed to pick up. And I guess the medication they're looking for, they're usually allowed to pick it up. But documentation over like health conditions or what we've been visiting with patients, that usually is more protected. Of course, everyone's allowed to request that information, but it would go directly to them. And for stuff that's more verbalized, it depends more like case to case. Like people can bring other people during visits and stuff like that, that I've never seen that to be an issue regarding HIPAA.
And do your clients have access to their records?
From what I've seen, typically we don't give them like a copy of what we have for them, but they always do have the right to request a copy of their health record, and we would provide that for them if they requested it. I know that it's becoming more and more of a thing where we're trying to bridge that gap to where people do have more access to their health record information, but for the most part, from what I've seen so far, it's not really a direct access thing. They would have to request a copy, basically, if that makes sense.
Yeah, that makes sense. And also something I've been saying now that you mentioned that is there's a lot more uses of portals.
Right.
And all that. So I know at the doctor office that I go to, they ask, do you want access to your portal? So they would also see their information there. But like you said, it sounds like it's something new. It seems like.
Yeah, it's becoming more of a newer thing that they're implementing ease of access to medical records.
So it's like, for the most part right now, it's still a little bit limited because not all the doctor's places offer that portal, but also if it is like a written record, they'd have to request it.
Right. That's what I've seen in my experience so far. I don't know if it's been rapidly more and more coming out or how fast it's coming out. But from what I've seen, yeah, that's typically how it's working, but it's becoming more and more of the portal type of thing.
Yeah. So on that note, you have access to, as a pharmacist, I can imagine, you have access to a whole lot of patients' records. How do you protect that?
There's a lot of ways that hospitals and locations go about protecting information, mainly all the time where we're accessing files to try to always kind of keep your profiles locked so no one else can access it unbeknownst to you, so that you're not leaking anything. Talking about patients around other people is also kind of more limited. And it's also mainly just identifiable factors. So like, we're not just going around saying people's date of birth, their names, stuff that can easily identify them to other people around, because that would be a breach of their HIPAA. Also not disclosing anything that that you see during your time at those visits outside of the office. So not going home and telling you like, oh, hey, who did I see today at the office? Blah, blah, blah. And this is what they came for. So stuff like that is a big deal. And it's a really big breach of someone's privacy. I know that there's a lot of encryption that goes around, and sometimes hospital locations will even forbid you from using like your own personal devices on internet, and so you have to use like site-specific electronics so that you can only log on to certain things from those devices to access patient information.
So there's many ways that you protect.
Yeah, there's a lot of ways, but of course there's humans involved, so there's always ways that things can go wrong as well. Mm-hmm. But it's a really difficult balancing act.
So along with that, I know that usually patients will transfer to another pharmacy, or like in a hospital setting, then patients will be discharged. How long do you keep a record after a patient is either discharged or transferred? And how long, I mean, like what I'm asking is, how long do you usually keep those records?
Yeah, so those records are actually surprisingly kept for a really long time. And that's more due to potential of audits that the Board of Pharmacy or any other kind of regulatory board can impose. It can range from anywhere from like 3 years all the way up to like 10 years, just depending on how the information is stored. If it's like a paper copy, or if it's an online copy, or depending if it's a prescription or like a note that we wrote about somebody, that can really alter how long we're supposed to keep those files for. But it typically is actually a long time.
And when would you know, like, to dispose of it? After that time has passed?
Like, yeah, so after that time has passed, you typically would get rid of that information.
So you kind of mentioned this, you kind of answered this question earlier, but do you consult your patient's care with colleagues? And if you do, is there like limits to what you would talk to your colleagues about?
So in terms of limits, I would say not really, because typically from what I've seen, everyone has access to the same information. And like I said earlier, we're all bound by the same law, so we're all trained and taught to protect that information the same. And in terms of discussing patients' like care and stuff like that, yeah, I would say there's a huge push now to get everyone to work a lot closer together. So having, doctors and nurses and pharmacists and mental health providers and kind of everyone who is involved with that patient to kind of care for them as a team rather than individually, and leaving space open for kind of stuff to fall through the cracks. So, and that's called patient-centered care, and that's becoming, that's a really big ideal, I guess, of how we want to take care of patients. So we're not thinking of kind of just within our scope. So like a pharmacist, I would think more of like the medications, versus a physician would think more of like the physiological, how the body works and things that can go wrong there, versus you are looking more towards like mental health stuff. So everyone's kind of looking at a different piece of it. And so working together with colleagues is a very important part of that. But again, it's very important to also protect that information and data with the patient. So again, that goes to kind of like not discussing things openly, where a bunch of patients would be waiting till you get to an office to kind of discuss the case, and only accessing things when you're in private so that no one else can kind of glance over your shoulder and look at stuff. So hope that answers your question there.
So what I'm hearing is you work with colleagues just to kind of make sure you're not missing any key details that are important. Like, let's say you're working with a doctor, so you don't miss something physiological. You work with mental health providers to make sure you're not missing anything cognitive or emotional disturbances or anything like that.
Right, and we're doing that so that the patient gets the best care that they need, so that they're able to see everyone that they need to see as well.
So you kind of answered that. So how much information? So I don't know if this is a thing with pharmacists, like power of attorney or anything like that. Mm-hmm. But if you do have a family who kind of has that power of attorney, how much information would you share with somebody who is a power of attorney? And also, you also kind of answered this, but more into details. What would you share with a family member who doesn't have that power, or just any random family member, let's say a sister or a husband, wife, who says, I don't have any documentation, but I need to know what they're taking.
Right. So yeah, we are bound by the power of attorney status as well. And that really depends on whether the patient is able to care for themselves or not, and whether that power of attorney has taken over. Because once you have that full power of attorney and someone is fully taking care of you, they basically act as if they were you. So they would have access to all of your medical records and all of the decisions that come with that. So they would be making all of the decisions and stuff like that. So if someone has power of attorney and it's currently active, they would have access to pretty much everything. But a family member who doesn't have that power of attorney, or if the power of attorney hasn't yet become active in a sense, then it would have to be all through the patient. So we wouldn't be able to share anything with the family member unless the patient was there, present, and willing to share that with them. So it just really depends on kind of how the active statuses are on that. But we do have power of attorney, and we do base off of that. And again, if it's just a family member who's there, we would also have to have the patient there willing to share that information.
And would you get like a written consent, or would you also like accept the verbal consent?
For the power of attorney, I think it would have to be all written legal documentation stating that they have that power of attorney active. But if the patient is there, then we can verbally tell them like, hey, this is sensitive information. Are you okay sharing with them? And then they would verbalize whether they want to or not.
So if they have power of attorney, they don't even need to ask. Like they have that,
Mhm.
so it's okay. But if not, then a verbal consent is sufficient to be able to let them listen into what's going on, as long as the client is present.
Right. From my experiences, that's what I've seen. Yeah.
Okay. So this is gonna like off track a bit, but another part of privacy and confidentiality is, at least for therapists, we discuss with our patients, ahead of time. I cannot say hi to you unless you say hi to me first when we're in public, and we happen to run into each other, because if I see you and I say hi to you, then someone's gonna ask, how do you know them? And that would be a breach of confidentiality. So I was just curious to know, do you have any protocols, like if you see a patient in public, but I'm also imagining if you don't see your patients at all, or if you only see them for like 20 minutes, that's completely different.
I don't think we have any protocols like that. At least I haven't heard of anything that would bar me from saying hi to a patient or them saying hi to us in public. Of course, I typically tend to not really call out like, oh, hey, I know you from our doctor visit, stuff like that. Like I obviously don't go around looking for my patients to kind of pick out of it in public, but if they come up to us and say hi, if they've known us for a long time, I haven't really seen that be an issue, because we're not sharing any kind of health related information. Like we're not saying, oh, I treated you for blah 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 or something like that. Like if we're not saying that, that would be a big breach. But if they like come up and say something, I guess if it's through their own disclosure, I think it's okay, if that makes any sense. Because that gets into more of a like grayer area.
Yeah. It is. I feel like in any field with HIPAA or privacy or confidentiality, there's the black and white, and that's mostly like, it's easier to see that one like on textbooks, but it is actually just a whole lot of gray.
Yeah.
And that's why staffing is so important. So yeah, when you say, it depends on what is being said, definitely.
Right.
So that's it for all the questions I had for you, and I was wondering if you had any questions for me.
Nope, not at this moment.
Okay, well, thank you so much for being part of this interview, and I'll talk to you later.
All right, thank you for having me.